So the current situation, as called by ECDC, is that approximately 25,000 people are dying each year in Europe from drug-resistant infections. It's always really difficult to get these numbers right. It's how much is related to their underlying disease states, how much is related to the fact that they have had multiple treatments with antibiotics in the past, how much is related to the fact that they're old and that their comorbidities are such that they're going to kill them. 25 years ago when I started out, it was rare to see young women admitted to hospital for pyelonephritis. Now that's an event that happens every single day. And unless we do something about it, it's going to get worse. Lord O'Neill, commissioned by Prime Minister at the time, David Cameron, did an economic review of the impact of antimicrobial resistance. And you can see that his estimates were 66 trillion or $100 trillion. I mean, we can't even estimate what that means. And that the estimated deaths would be 10 million by 2050, far exceeding the deaths from cancer. But we're already, in essence, seeing deaths from common infections, common bloodstream infections, E. coli, MRSA, that exceed the deaths from breast cancer in this country. And no one's talking about it. We also need to remember that we've come a long way. Only 100 years ago, 1/3 of deaths were directly related to antibiotics. 1 in 3 people died from antibiotics. And now it's down to just 3%. Still a large number, I think, for things that we have antibiotics to treat. And a lot of these deaths are probably related to our own immune responses. Of course, in some parts of the world, such as Africa and Asia that don't have access to antibiotics, these deaths from antibiotic infections are much greater. And so not only do we have a problem with some inequitable access and inequalities in this area, we also have the area of making sure that when we are going to have antibiotics freely available, and we have antibiotics that are essentially free to our population to use, that we use them correctly. The improvements that we saw in this, the mortality from infections was not just due to antibiotics, but it was also due to improvements in sanitation and improvements in immunization and vaccination. Immunization across the world is really reaching quite a high level now, in large part helped by the WHO actions and also by the Gates Foundation. But sanitation still has a long way to go. So there are still many parts of the world where effluent runs along the side of the street, where animals live in close proximity to humans, and the interchange of genes between humans and animals happens frequently. The latter part of the century, so since the sort of 1970s, all of the improvements that we have seen have been due to heart disease treatment, cancer treatment, surgery. All of those are dependent on us, and people surviving from these diseases are dependent on us having antibiotics available to treat them for complications of their illnesses or for complications of the comorbidities. We also know that antibiotic exposure in our population is huge. 1 in 3 people receive an antibiotic each year in the community. And at any one time, 1 in 3 of our hospital population are on antibiotics. And then when we look at the hospital population on antibiotics, more than 80% of them are on a broad spectrum antibiotic. So that's the starting point of an antibiotics, as many of you will be aware in hospital, is comoxiclav, a broad spectrum antibiotics. That's where we start from. How many people have you seen come in on penicillin V in the last year? The other important point I wanted to make here is that as we get older, we get more antibiotics. And in long-term care facilities, 2 in 3 people have had an antibiotic each year. And 1 in 10 people have had more than 4 antibiotics in the last year. So the older we get, the more antibiotics we need and the more antibiotics we use. And unless we tackle these inequalities in antibiotic use and in the healthcare that we deliver to these people, we're going to see a rising climb in antibiotic exposure and therefore antibiotic resistance. This graph is just to show us that there is limited data globally on antibiotic use. This data comes from IMS Health, now IQVIA. And what we can see is there's large components of the map which have no antibiotic use data available. We can also see that there are some components that have very high usage of antibiotics, particularly in the southern European countries, but also across Europe and across America. So we in the Western world need to fight against this antibiotic consumption and need to think about what we're going to do if we want to drive down resistance. We know that antibiotic resistance emerges really rapidly once we expose bacteria to the antibiotic, usually on an average in about 2 to 3 years. But for those people who've been starting to use ceftazidime avibactam, and our estimates are that 1,000 patients have been treated in the UK with ceftazidime avibactam in the last 18 months, we're already seeing resistance. There was an ECDC alert, a risk assessment showing that there's a rapid emergence of resistance to this antibiotic. And there's also already been one outbreak of ceftazidime avibactam resistance in our hospitals. So infection spreads rapidly and resistance emerges even more rapidly. And where we used to say that resistance takes a number of years to spread around the world globally, and when we talked about resistance to carbapenems, it was seeming to take about 3 years from detection in one country for it to become global. The case of colistin resistance and detecting colistin resistance gene, MCR1, was rapid. So it was detected in China, and then very rapidly, people who had whole genome sequencing of gram-negative isolates around the world checked those isolates and found that we already had resistance. When the MCR1 gene was detected in China, and we knew exactly what the gene was and what it looked like, and we tested 30,000 genomes that we had sequenced in Public Health England, we already found that we had 15 isolates of MCR1 in this country. Some of those were imported through salmonella infections, and some of those were also in E. coli infections. So when we find new genes, right now, they're probably present globally. And that's because of rapid human travel, food travel, and the fact that we have such short time periods between spread. And this has always been talked about as important for pandemic flu, but it's now just as important for antimicrobial resistance. You will have seen variations on this picture before, but this is just to remind us that anything we talk about in antimicrobial resistance needs to be talked about in a One Health format. And by One Health, I mean everything to do with animals, humans, and the environment, and our food. All of those components together. And what this means is that when we have an antibiotic resistance gene, it can get to us in one of two ways. It can get to us through the environment, or it can get through us through the exposure to that gene in our food, in our environment, and it can develop in the gut. Resistance genes, and particularly the ones that we particularly worry about, are often spread in something called plasmids, mobile genetic elements that move from bacteria to bacteria. They're as promiscuous as you like. And what I mean by this is that they can spread by any bacteria at any time. And we know that if you look at outbreaks now that we see in carbapenemases in hospitals, frequently the carbapenemase gene is in 5, 6, 7, 8 different types of bacteria at the same time. So tracking a single bacteria is no longer useful. We have to start tracking genes in a more efficient format. And again, just to put this graph into perspective, this is who lives in the UK right now. So humans are a little tiny component of that. The majority of people living in the UK, or the majority of animals living in the UK are chickens. We all know that chickens get a lot of antibiotic exposure. And those chickens only live 42 days each. So you know how many more chickens there are in the total in the year. So we can multiply that number by about 8. It's also important that we also have lots of domestic animals. And while we in the UK have made great strides in reducing our antibiotic use in farm animals, the use in domestic animals is relatively unmonitored still. And we know that often the human antibiotics are being used in those domestic animals because often they've got similar infections to humans. So when we look at dogs and cats, almost every one of us, myself included, has a pet at home. It's also interesting to look at fish. nearly as many fish living in this country in your fish bowl or your fish ponds as there is humans. The UK AMR strategy is founded on 3 pillars, and those 3 pillars are prevent, promote, and protect. And by prevent, we think about things like infection prevention and control, preventing infections. I also put preventing antibiotic use into that section. We need to think about making sure that we promote the idea of new drugs, diagnostics, and antibiotics and alternative treatments for infections, but also promoting the idea that everyone gets immunized and vaccinated as fast as possible for the diseases that we can prevent. And we need to protect the drugs that we have. Protect them in making sure that we have them for the future by using them prudently on a day-to-day basis. As all of you in this room, I'm sure, are aware, the government announced 2 ambitions halfway through this strategy. The first is reducing gram-negative bloodstream infections, and they've particularly focused on healthcare infections, not just hospital, which people keep equating to both. And by healthcare infections, it was trying to reduce those that had been associated with the hospital in the previous 30 days, but also importantly, in primary care, those that have received an antibiotic by the GP in the 30 days prior to the bloodstream infection, really bringing the whole health economy together. Because by treating the wrong infection, or by treating an infection inadequately with antibiotics or over-treating patients, we're just as likely to see problems. We've also got an ambition to have inappropriate prescribing, and inappropriate prescribing is antibiotics that are unnecessary for that condition right now. And the work that PHE has done and showed is that approximately 20% of prescriptions in primary care are currently not required. And those prescriptions are predominantly not required for things like sore throats, upper respiratory tract infections that are still frequently given antibiotics. And so in the studies that we've looked at and in the expert elicitation exercise that we performed, and in the case records from GPs that we looked at, 70 to 80% of people attending general practice with sore throats are still receiving antibiotics. So what can we do? We can encourage prudent, appropriate antibiotic prescribing. And there's a number of actions that we can take. We can compare our prescribing to those of our peers. We can follow the guidelines. And we can use toolkits to help us talk to our doctors, nurses, pharmacists in our organisation to improve our antibiotic use. These are some of the toolkits that are in place in the UK. Start Smart Then Focus, which was led by Diane, and is a toolkit for UK hospitals, trying to get people to start the right antibiotic, and then once the antibiotic is started, to review that antibiotic prescription at least once in the first few days. In hospitals, we're in an ideal place. Patients are sitting there. We have the possibility of actively reviewing antibiotics every single day and stopping them when they're not necessary. And contrary to some of the myths, you don't need to complete an antibiotic course if the antibiotic course is unnecessary. You only need to complete it if you're trying to treat a defined infection that you know a minimum duration that you need to treat. For everything else, there is no problem in stopping. Stopping an antibiotic if people don't have an infection does not lead to antibiotic resistance. We also have resources for primary care called Target, and there's training resources, information leaflets, audit tools, and there's particularly a sheet that you can hand out to your patients which allows you to tell the patients how long different common infections are going to last before they get better. And Health Education England have developed a learning resource that anyone can access within the NHS and is worthwhile trying to get your junior doctors to access it. Show of hands, how many have antibiotic stewardship as a mandatory training requirement? So almost nobody has antibiotic stewardship. How many of you have infection prevention and control as a mandatory training requirement? Okay, so this is what we have to do, guys. It's our job to go and look at this, and both nationally and at a hospital level, we need to tell people that this is just as important as IPC. They need to be combined. We can't have the infection prevention and control team and the antimicrobial stewardship team separate. They are one. They're the same. They're working together to protect our antibiotics.
Lots of other resources out there. PHE have an antibiotic resource handbook so that you should look at if you need to figure out what you need to do. NICE guidance is on antimicrobial stewardship, which we are required to implement. We also have guidance coming out from NICE and PHE on an almost quarterly basis now on common infections, which has been evidence-based, and I know many of you will have fed back on the recent UTI guidelines. And just on to say what's going well. So after a bit of the doom and gloom and come on, we are actually getting better in this country. And one of the reasons why we're getting better is that we've introduced incentives to the hospital and community. Not to individuals, but to really push and raise awareness about this important issue. You can see here what they are, and I'm sure they're well known to you, but essentially these are sort of summarized from the last few years rather than just giving you each year in detail. But it's all about reducing total antibiotic use and reducing broad spectrum. And those are my two mantras over and over again: reduce total, reduce broad. Doing one and not doing the other will still expose the same or more people to antibiotics. And in primary care, they have really worked hard and should be congratulated every single time you get a chance for what they've done. This is the reductions in primary care antibiotic use. When we started this program in 2013, there were more than 800 prescriptions per 1,000 of the population being dispensed in this country, i.e. that's equivalent to about 8 out of 10 people, but we know it's not because people get repeat, but probably close to 4 out of 10 people getting an antibiotic. Last year, it was down to 620 people getting 620 prescriptions per 1,000 of the population. So reduced by more than 10% in the amount of prescriptions dispensed. And the broad-spectrum antibiotic use has also declined. The broad-spectrum antibiotic use had a big decline around the time we were pushing C. diff, but what seemed to happen when we did that is we just gave an alternative. So we switched one antibiotic to another. So we stopped our quinolones and cephalosporins, but kept giving others. And I think that's always the easy decision, isn't it? Which is the lesser of two evils, rather than that they're all evil at some level and stop everything. But I can see lots of colleagues from hospitals here. Hospitals have still got a lot of work to do. This is my own hospital, so sorry guys. I always feel better about putting my own hospital up so no one else can give up, so Marissa and Damien apologise. But we have done well, not as well as we'd like. So total antibiotic use is still really high in hospitals. It's not declining. The Royal Free has seen some declines from a high start, but it's not declining overall, and if anything, it's increasing. Piptaz, helped by the antibiotic shortage last year, has seen a precipitous decline. And I do think that one of the reasons why we've had an increase in total antibiotic use over the last year is because it's the 2-for-1 shot. So people have reduced their Piptaz but are often using combination antibiotics. That's what we've been doing in the Free for some time. Amoxicillin and temocillin is our preferred hospital-acquired pneumonia treatment, for example. Temocillin is often used for UTIs, and that's got a much higher DDD burden than others. But that will change next year, and so these graphs will be redrawn. For those that don't know, and you'll see some, we'll try and put something in the SBAR report this year. The WHO ATC DDD guidelines are changing. So amoxicillin is going to go from 1 to 3 grams, and temocillin from 2 to 4 grams. So what's changed from Piptaz going from 1 DDD to amox and temo to 5 DDDs will go from 1 to 2. So another impetus to try and move and change your antibiotics. As you should all know, we've also tried to push towards narrower spectrum antibiotics by modifying and adapting the WHO EML Aware Index, Access, Watch and Reserve, and trying to push people to get to 55% of your antibiotics being access antibiotics, the narrower spectrum agents. And you know, we have made a change. Every year from 1998 to 2014, essentially we increased our antibiotic use in this country. We started monitoring it very carefully in 2010. By 2014, when we started the program, it had gone up to 22.8 defined daily doses per 1,000 of the population. That was in the top half of Europe, and that was more than 50% higher than the best countries. Netherlands, Sweden, Norway. They sit about 14. Just to give you a perspective, how much lower they can go. And in 2017, we reduced to 21.2. So we are getting places. The aim is to get below 20 by 2020. And we'll aim to get even lower than that by 2025. Remember, all of the data you've seen here and all of the other data that PHE are publishing are now available on the PHE Fingertips portal. So you should go and look at this and compare yourself to your peers for everything from healthcare association infections, from everything to do with antimicrobial stewardship, bloodstream infections, IPC, etc. We're also working on the public, and you'll have seen the dancing pills. And this campaign is really there to help support prescribers. It is there to educate the public, to tell them when to take antibiotics and not. But really it's there to say, take your doctor's advice, take your nurse's advice, take your pharmacist's advice. When they say you don't need an antibiotic, then feel reassured in that. And all the tools are there to help support those decision-making processes. E-bugs, also important, and so educating children is an important component of everything we do. If we educate children and get them to believe they don't need antibiotics for the future, then that will be a good start from where we are right now. And finally, AMR is a wicked problem, and for those who don't know what a wicked problem is, AMR and climate change are grouped together. And this means that they are highly impervious to resolution. So we know that this is a really complex problem, where bacteria had a resistant gene, maybe 20 years ago. Frequently today, they have 5. They're mutating rapidly. It's difficult to define. Now you know, if you're trying to explain antimicrobial resistance to somebody, how complex it is. We're talking about a wide variety of pathogens, a wide variety of organisms, a wide variety of resistance mechanisms. It's not as simple as explaining flu. And that makes it increasingly complex. It's also really important to remember it's multi-causal and socially complex. The more deprived our population, the more antibiotics they use. The more deprived our population, the more comorbidities they have. The older our population, the sicker they are. These are all factors that drive both infections and antibiotic use. And so just talking to infection doctors, nurses, and pharmacists isn't going to be enough. We need to bring that message out wider, and we need to make sure that our patients and our population understand this better. Thank you.